It's 10 o'clock by my time, so I think we can start, Musa. So over to you.
Thank you so much. Good morning, colleagues. Greetings to panelists and ASSAf in particular. And I'd like to introduce myself. My name is Mosamo Shabela. I am Acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal. And today I am chairing this session in my capacity as the chairperson of the Standing Committee on Health within ASSAf. Now, it's a real pleasure for us to welcome you this morning to host this seminar in particular. It's long overdue. You would know that the issues around ivermectin have been within the scientific debate for some time now. But also in a very strange way, it's actually good timing given the recent developments around ivermectin in the country. So I hope that we can, in our effort to try and understand ivermectin and what it's about, the evidence around it in particular, the risks, the benefits, and all the legal implications, that we can also take into account some of the recent developments as we engage you. I'm hoping that you are all as keen to hear the evidence that's going to be presented, because we always say we don't have strong enough evidence around ivermectin, but at the same time, there is so much pull towards ivermectin in certain sectors of society. So I'm very excited to introduce this seminar and to chair it. But before we proceed, I would like to invite the CEO of ASSAf, Professor Himla Sujal, to welcome us. Thank you. Over to you, Himla.
Thanks, Musa. Good morning, colleagues. It is indeed a pleasure for ASSAf to host this very important webinar. Musa has given you the background to it. All that remains for me to say is that ASSAf is well entrenched into dealing with issues of relevance to society, particularly using an evidence-based approach. And today we have amidst our panelists, people who do just that. It's not just air talk. They review the information and the evidence at the coalface at which it presents, do critical analysis of that, and are here to share with us some of their insights. ASSAf is still working virtually. So, virtual engagement has its advantages, that we can do a lot more without having to organize face-to-face meetings, etc. And I must say that our colleagues and members and partners have come to the party in joining with us to ensure that we bring interesting topics and debates to the fore, to allow our scientists throughout various sectors and sub-disciplines to engage. So today is one such engagement. Throughout the latter part of last year into this year, most of our engagements on social media was about ivermectin. Where can you get it? Is it valuable? How can you do? How can you? Why is the regulator not reacting, etc., etc. I know from my own family, I was bombarded with questions about ivermectin, and many people got it somehow through the channels and would vow to its value. So today, colleagues, we have an eminent panel of speakers who are going to share with us their perspectives on it. Unfortunately, one of our panelists, Professor Vinny Naidoo, was called into another meeting and is unable to join, but has provided his input. So I hand over back to Musa to lead us in the deliberations today. And I wish to welcome you all. I see our numbers are growing. So it is obviously an interest to one and all. And we look forward to your participation in the discussion. There are, the options of asking your questions in the Q&A, and we will help the chair in identifying those as he orchestrates his duties today. So over to you, Musa, and thank you all once again.
Thank you so much, Himla. And once again, welcome everyone. And we are going to try and move as swiftly as possible through the presentations. And as you've heard, the first presentation we're going to have on this seminar on ivermectin with regards to COVID-19 treatment in particular is going to be that of Professor Vinny Naidoo. For this one, we are going to have to play a recording that we have done beforehand. So unfortunately, he will not be around to discuss the details around some of the things that are presented, but not to worry, we've got a capable panel that's going to address your issues here. But I will give you briefly just to say that Professor Vinny Naidoo is from the University of Pretoria and is a known veterinarian, and will be sharing a veterinary perspective on this. It's important to note that he's been very critical in the discussions around ivermectin, particularly as part of technical working groups within the Ministerial Advisory Committee. I understand that together with Tamara, they've been at the forefront of reviewing this evidence to advise the country on what is happening. But in particular, he is going to help us understand what ivermectin is. And as you will recall, that it's been registered in the country for a while, but within the veterinary sector, only recently it's been registered for human use. So Dr. Palan, over to you. If you can introduce the recording, I would really appreciate it.
Share my screen.
Good morning. Thank you for the invitation to present today. Today I'm going to talk about ivermectin from the perspective of a veterinary pharmacologist. I'd also like to apologize for not being able to do this live today, but unfortunately my schedule could not accommodate a live session. So the first question is, what is ivermectin? Now, ivermectin is actually not a single product. It's a mixture of smaller molecules known as ivermectins. They are the fermentation products of streptomyces, so they are natural compounds, and they are part of a larger group of chemicals known as the macrocyclic lactones, which are made up of the ivermectins and milbemycins. As you can see from the chemistry on the left, the product all have similar chemical structures, which is this macrocyclic link leading to their specific name. Ivermectin has been used in veterinary medicine for a number of years. Its use in veterinary medicine predates its use in people. In the veterinary world, the product is known as an endectocide, and that means this is a product that is effective against both endo and ectoparasites. As an anthelmintic, very effective against your nematode parasites, but not effective against cestodes and trematodes. The product is also very effective against ticks and fleas, depending on life cycle, mites, and parasitic fly larvae. When looking at its use in people, the drug is very effective for the treatment of mites, your zoonotic diseases such as your cutaneous larval migrants, river blindness, and filariasis. Ivermectin has become such an effective drug in both people and animals, the inventors were awarded the Nobel Prize for its discovery because of the huge difference it's made to farming and human life. How does ivermectin produce its beneficial effect? Ivermectin targets the neuronal system of the parasite and it enhances the effect of GABA. This results in an effective paralysis of your parasite and an inability of the parasite to maintain itself in the body, which then results in it subsequently being cleared. Since GABA is a system shared between parasites and mammals, it's not surprising that the drug can have an effect on mammalian GABA, and this is where you see your typical side effects. And in animals, your side effects can be quite marked, such as CNS depression, paralysis, coma, and sometimes even death. One of the questions we always get is, where is veterinary ivermectin registered in the country? There is unfortunately a misbelief that SAHPRA, or the South African Health Products Regulatory Authority, controls ivermectin. It's not the case. Ivermectin is actually controlled by the Stock Remedies Act, which is Act 36 of 1947. This act falls under the Department of Agriculture and is responsible for the control of products that are available over the counter for use initially by farmers, but nowadays for also pets and other animals. The act is not that restrictive in that it is meant to allow a farmer to treat an animal without having to consult a veterinarian. However, the act is strict in that it restricts the use of the product for animals only, and when used over the counter, it can only be used according to its labeled indication. If the product is prescribed by a veterinarian for extra label or off-label use, a veterinarian may allow for the deviation of the registered indication. However, it's very important to note that no authority is granted to a medical professional by this act, which means veterinary ivermectin cannot be used in a person. It is illegal, and that authority is actually in this act. So now we get onto the actual crux of this discussion. Ivermectin as an antiviral drug. Is it new? Is it something novel? Should we be surprised? And the answer is actually no. Ivermectin has been repeatedly tested over the years as an antiviral drug. We do know that it actually does have an effect against a number of other viruses under lab conditions. However, the question is, how effective is it? And so far, ivermectin has not proved itself to be a highly effective antiviral agent. So it's not surprising that when the drug was tested against the COVID virus, that you do have an effect seen in the lab. So up here we have the graph from the paper where the antiviral activity of ivermectin was described. And as you can see, it was done with cell cultures with the virus grown. And in comparison to the control on your graph, which is A, you can see there was a clear drop in viral load. What is important to note is that the effective concentration reported is quite low, but it is still around 1.7 micrograms per mole. And this is where the importance comes into play. Ivermectin as a drug is actually administered at a very low dose of 200 micrograms per mole. So the question now comes about, can ivermectin as a drug, which as mentioned in the previous slide, cannot reach the effect needed for an antiviral activity against other viruses, be effective for COVID? And this is where the debate came in. Should ivermectin be used? To understand this, we have to look at a principle in pharmacology, which is the pharmacokinetic pharmacodynamic interaction of the drug, or also known as PK/PD. So in the picture in front of you, you have a portion on the left, which is outside the body, and the portion on the right, which is inside the body. So we administer a formulation of your product. That formulation allows for convenience of administration. The drug from that formulation has to be released. It has to go into solution before it gets absorbed into the body. Once in the body, it's subjected to the normal pharmacokinetic processes, and part of that process is getting the drug to the tissue in high enough concentration. It is only in the tissue when you have high enough concentration that you will get an effect. So when looking at ivermectin and its effect against COVID, you have to ask the question, will a dose at 200 micrograms per kg in a person result in an effective concentration in the lungs? And if you consider the dose administered and the effective concentration, it suddenly becomes hard to understand how that drug can reach the lungs in high enough concentration. To demonstrate the effect of dose, pharmacokinetics, and effect, in a published article, the following graph was made available. In this graph, you'll notice the red line, and this red line is the effective concentration that needs to be reached. And they modeled 3 dosing scenarios. The first scenario is the recommended parasitic dose of 200 micrograms per kg given weekly. The second scenario is 120 milligrams given weekly, or the third scenario being 60 milligrams every 3 days. And what you'll notice immediately from the graph is none of the concentrations were able to reach the effective concentration. And what this shows is that the pharmacokinetics of ivermectin do not allow for adequate concentrations to be reached in the lungs as a single therapeutic agent. And this is where the question now comes about. Is ivermectin likely to be effective? Just looking at this modeling, one can immediately say it is unlikely to be effective. So the next question would be, what dose would I have to give? Looking at the concentrations and the need to get to that red line, the dose needs to be likely much higher at around 12 to 15 milligrams per kg, which you can see is a significantly high dose. So how toxic is toxic? Now, ivermectin has been used for a number of years in both people and animals, and in most cases it's safe, although there are a number of pharmacovigilance reports of spontaneous adverse drug reactions. At the recommended dose of 200 micrograms per kg, which is the dose in both people and animals, the drug is very safe. You see very few side effects. However, it's when you go to your higher doses that you do get toxicity, and this toxicity is generally linked to the neurological effects of the drug. This is a table that I drew from the material safety data sheet for ivermectin, and what is important is the oral LD dose. And what you can see that in people, the toxic dose is near 15 milligrams per kg or higher, which as per the previous slide is very close to the effective dose. So you have to ask the question, are you going to cause severe toxicity in people by trying to treat COVID? This then asks the different question. If ivermectin has the chance to cause harm, should a person be taking the drug in the absence of medical supervision? So the debate is not will ivermectin work against COVID, it is how safe is it to use on your own? Should a person go out and buy ivermectin to treat themselves, specifically the cattle formulation? And the answer is definitely not. Besides being illegal, we do not believe that a person should be taking the drug in the absence of medical supervision. So when ivermectin is used, we believe a medical doctor has to be involved. Now, in addition to the drug just being toxic, something we need to realize is that the body has a protective mechanism against ivermectin. It is known as the P-glycoprotein pump, or the MDR gene. This pump is present in the intestines and is actively excluding ivermectin, but it's also present in the blood-brain barrier, and it actually prevents ivermectin from getting to the brain and interfering with the GABA neural systems. And this is the reason why the drug is very safe in mammals. However, this pump is not always present. Now, in this illustration, just to show you what would happen, the white part of the slide where you see your black dots will represent your drug, either in the intestines before absorbed or in the bloodstream before the brain. When it gets into the cell, this pump will physically take out the ivermectin and pump it out of the body. So it becomes an exclusion system such as a bulge pump, and it becomes protective. And of course, what this means is if you have a deficiency or an effect on this pump, you can get toxicity. So when does this actually happen? Now, the interaction of drugs with the P-glycoprotein pump is actually fairly common. And this interaction could be to stimulate or inhibit the pump. In this case, we are interested in pump inhibition. If you do have inhibition of this pump, what would happen is you would get enhanced plasma concentration after an oral dose, and this will then enhance CNS concentrations, and this could then result in toxicity. So from medical literature, we do know that your orange juice, grape, and grapefruit juices can influence this pump in a negative way. There's also evidence to show that certain drugs such as doxycycline and your macrolide antibiotics can also inhibit these pumps. So all in all, what will happen when we cause pump inhibition? Now, we know this as a very common veterinary side effect. It happens in collie and collie cross dogs, and these animals are highly sensitive to the effect of ivermectin. probably around 30% of the breed are genetically deficient in this PGP pump. And as a result, a standard dose of ivermectin causes severe toxicity, depression, and usually death in these animals. Now, in people, there's also been descriptions of the pump being absent. It seems to be a genetic aberration. And in these people, you also see the same signs of CNS, depression, and you can lead to death. So all in all, ivermectin, while being safe, is related to normal physiological functions. As soon as this function is interfered with or absent, you can get idiosyncratic toxicity resulting. And this then introduces another danger with using ivermectin in people without monitoring them. For the last part of the presentation, I thought I'd go through some of the common questions that we've received as a veterinary faculty. So one of the questions is, can I safely use cattle ivermectin in myself? Well, we don't know. Cattle ivermectin is available as an injectable formulation, and very important to note that there are two different formulations. You have your immediate release formulation, which is the drug getting absorbed for immediate effect, and you also get a long-acting formulation, where the drug has a prolonged effect over a month, and the doses do differ. What we do know is that ivermectin is not a simple solution. It is dissolved in propylene glycol, and this was what allows the drug to be absorbed in animals. When taken orally, we have really no idea of how the drug is going to be absorbed. It could be well absorbed, it could be poorly absorbed. Nonetheless, because we don't know what's going on, we shouldn't really be taking it. Now, the slide in front of you is from a study in sheep in which 3 different ivermectin formulations were tested. All the formulations had the same amount of ivermectin, all of them were dosed the same, but they had a different formulation. And here you can see 3 different graphs, and the standard formulation being purple, you can see had relatively okay absorption, but the 2 other formulations had superior absorption. And this is what we are potentially concerned with people. What happens if the cattle formulation releases ivermectin in a much higher concentration than your medical tablets? You can have toxicity, which can become dangerous. Of course, the next effect could be ineffective absorption. Now, we know that you could get normal levels, which is therapeutic or potentially toxic, but you do get the reverse scenario. What happens to a drug that is not properly absorbed? In this case, you get suboptimal concentration, you believe you're being treated, and as a result, you may put yourself into danger because you could put yourself in a situation where you could expose yourself to an infected person thinking, well, I'm on ivermectin, I'm protected. So the kinetics of the drug is important for effect. If we don't know the kinetics, we shouldn't be using it. The next question we typically get is, can I use topical ivermectin on myself? Topical ivermectin is available as a cattle drug as well. It's applied onto the back of the animals and then has an effect. So the question is, if it works in cattle, why doesn't it work in people? Well, let's look at the pharmacokinetics first. Now, quite a few different formulations have been tested for topical application in people as well as in different age groups, and all the studies have come up with the same conclusion. Topical ivermectin is very poorly absorbed in people. Now, in front of you, if you look at the green graph, you'll see that the levels reached are only 0.5 nanograms per ml at its maximum. When given at your higher doses, being the blue and the pink graph, you'll see that the concentrations are higher, but only around 2 nanograms per ml. So how effective is that? The oral tablets result in concentrations around 60 nanograms per ml. The concentration required to be effective against COVID from the lab studies was 1,700. So you can see immediately that the concentration is not very effective. Of course, the other question linked to this is, then why does topical ivermectin work in cattle? Well, one of the differences is cattle have different skin to people. But the other simple answer is cattle lick themselves, and they've shown that the topical formulation is actually absorbed orally in cattle. You don't get percutaneous absorption. The last question we've received quite often is, how safe is the drug if I take it daily? Now, I've had reports of a number of people buying ivermectin from your cattle cooperations, and they take the drug daily to prevent themselves from getting COVID. I've even heard the argument that taking ivermectin daily is more effective than getting the vaccine. So the question comes about is, how safe is this practice? When you know from the anti-parasitic use of the product that it's used seldomly and at 200 micrograms per kg. So from some pharmacovigilance studies, we know that in people that have taken the drug over a longer period of time, you do get neuronal toxicity, and these persons have ended up in ICU for a few days requiring emergency treatment. But from a toxicological point of view, and in veterinary pharmacology, we have a very important way of determining safety. And this is linked to food safety, since we don't want a person consuming meat, milk, eggs to be exposed to a drug that could be of harm. So we have a very established method, and this is reliant on lab animal toxicity data. So animals are inducted into different studies, and this is usually a rodent and a non-rodent species. And from all these studies, be it acute, subacute, reproduction, and chronic, we determine that one dose, and this is the lowest dose that had no effect in any of these studies, also known as the no observable effect level, or no. This dose is then divided by 10 to take into account interspecies difference, and then by a further 10 as an uncertainty factor. And the concentration you get is then known as the ADI, or the acceptable daily intake. The acceptable daily intake is described as that dose which a person can take in every day for the rest of their life without there being any appreciable risk. And these studies are published. And the one I looked at was published by the EMA. And in their conclusion, the ADI for ivermectin was described at 10 micrograms per kg per person per day, or for an average person of 60 kgs being 600 micrograms. If you had to look at this and compare it to the current ivermectin dose of 200 micrograms per kg, you immediately see that a person is being exposed to quite a higher concentration of ivermectin in treatment. Therefore, by going daily with ivermectin, you increase your chance of toxicity. And as mentioned previously, long-term use will result in CNS toxicity. So, all in all, to conclude, ivermectin is well recognized for its use in veterinary and human medicine. At the recommended dose, it is generally regarded as safe. However, when used in COVID, there is a lot of questions on the effective dose, because the dose seems to be close to the toxic effect. And this is the reason why, if the drug is to be used, I would recommend it to be used under medical supervision. And we also need to consider that as a single agent, the drug is unlikely to be effective. However, under intensive care situations where the patient will be on multiple drugs, which will then influence the kinetics of the product is likely to be more effective. And this is why we have to rely on clinical studies to determine whether the product will be effective or not. When it comes to the prophylactic use in healthy patients, based on the drug and the maths behind its use, I cannot see the drug as being effective. And that is where I would conclude. Thank you very much for your time.
Thank you so much. That was amazing. I don't know about you, but I've learned a lot from this presentation. I think that I don't really want to ruin it by trying to summarize it, but I think the point has been made that yes, it looks like there are antiviral properties, but the pharmacokinetics make it very difficult to find the right dose to use for COVID-19 in humans, especially at the kind of dosing that we will have to go to. But I think that a number of things were brought forward by Vinny that are very interesting around regulation, around medical supervision, around the PGP pump, which could really complicate things for people if there is no medical supervision. But also just thinking about how we take this forward in a responsible manner. And I think that's, for me, is really important. I don't think that the tone that he's sharing is that we should not necessarily consider it, but a large part of the presentation is about safety and protecting people from harm. So let's take the next presentation in terms of looking at some of the data that is there, the evidence that is there, the clinical data. And I'm going to invite Dr. Tamara Kredo, who is with the South African Medical Research Council as a senior research specialist and works with the Cochrane Review. And as you can imagine, she does a lot of the synthesizing of evidence. And Dr. Kredo, we're very honored to have you join us today, and we're really looking forward to you sharing your findings to date. I know that you've got a whole lot of other reviews you have done with other drugs around COVID-19, including hydroxychloroquine and so forth. So, but I'm sure you will be putting the issue of ivermectin in context. Thank you, and you're most welcome. It's an honor to have you.
Thank you. It's an honor for me to be here. Thanks, Prof Moshabela, and also for our hosts at ASSAf. I just want to check that the screen that you have is the presentation view, not the other view.
Yes, indeed. Thank you.
Okay, great. So, wow, thank you so much. What an interesting presentation we've just heard. And it's really great that Prof Naidoo, in his absence, it felt like he was here because it was such a clear presentation, was able to set the scene in terms of the pharmacology and the safety issues. So just to introduce myself, I'm Tamara Kredo. I'm based at the South African Medical Research Council. I'm a doctor and a clinical pharmacologist by my specialist training, but in fact, I work more on the public health and health policy side of pharmacology and how we prescribe rationally. And so really, I'll be able to move from what Prof Naidoo was speaking about and start to put, how do we make health decisions based on the evidence that we have before us? And as Prof Moshabela said, I'll be putting this into the context of other medicines and other decisions that we've had to make in COVID. So ivermectin, I will come to the nitty-gritty of the results and how it's looking at the moment, but I will present it in the context of the infodemic. How do we appraise complicated studies, and how do we understand best evidence and decision making? So I start every presentation with just disclosing with my disclosures. So I have no direct conflicts of interest, and some details are up there. But just to say, as someone who works in Cochrane, we are not, we really can't work in Cochrane if we are receiving any industry funding. But I do, everything is there. I do work for the MRC. So moving on. So I'm not sure if people have seen this before. Getting information off the internet is like taking a drink from a fire hydrant. It is overwhelming. And this is an old slide of mine because it was overwhelming before COVID. But when COVID came along, everything just went on high alert, and the volume of information has been overwhelming. There are publications publishing on this upswing in data that's coming through. A lot of them, as you might see there with the orange line, without data. So commentaries, editorials, kind of analyses, not the primary kind of data coming out, but there's so much to read and get through. It's hard to know where to start. A quick look on PubMed. That says 15th of Feb. Yeah, on the 15th of February, PubMed passed a landmark of adding 100,000 articles for a single disease in 12 months. I checked yesterday and they're almost at 120,000 results. So it's phenomenal. When you look at the number of trials that have been planned, and this is looking, I've been using a website called the COVID Network Meta-Analysis Initiative, where they're doing a living review, which I'll come back to. And there were 2,818 studies of treatments registered for COVID that were planned or ongoing. So these registries are so trialists need to register their studies before they start so that it's in the public domain that these studies are planned. And it looks like about 1,400 of them are still recruiting patients. So it's kind of phenomenal what science has been able to do, and people coming together, amazing science happening, but at the same time, this makes it really, really difficult for those that need to make decisions about their health in the context of all this information. And so the data that's coming through is coming through more quickly. And these preprint platforms, these platforms where people can put their data out before it's been peer reviewed. So it's not coming through the journal process, which can be a very long and slow process. And in many ways, it's wonderful that we can get access to data earlier, but there are pitfalls with the preprints. So they come through, they haven't been through scientific peer review, which is, so a peer has not checked the content. And even when you look, this one's a very common one, metrics that we look at. But do you ever read that little caution that's at the bottom that says, a reminder? These are preliminary reports that have not been peer reviewed. They should not be regarded as conclusive or guide clinical practice or health-related behavior or be reported in news media as established information. They are preprints, they are preliminary. And some of them stop there. They never come to light and they never come into the publication domain. But a lot of data is coming through that way. The other data that's been causing a lot of challenges is data coming through in press releases and slide sets. So suddenly a trialist they'll circulate a set of slides. So there's a slide set that came around on whether we should, the dosing of heparin for people with severe COVID or people in hospital with COVID, which even had some typos in it. Then you have your press releases, which of course use this very press release kind of language, major scientific breakthrough, announced the positive. These results showed that colchicine is the only effective oral medication for treating non-hospitalized patients. And when the paper came out, it wasn't quite as clear cut as the press release suggested. But this, takes you on a wild goose chase, constantly looking at the different data. And of course, this one is a very familiar one. Johnson & Johnson, we've now seen the data, but when we were hearing that Johnson & Johnson was going to be rolled out in South Africa, or not rolled out, I lie, we're going to be part of an implementation study for healthcare, people working in healthcare environments. All we had was the Johnson & Johnson press release, which had very high level data, vaccine candidates, 72% effective, 66% effective overall, with no confidence intervals or no links to the actual data for us to verify what did this actually mean. So very challenging health policy environment. Of course, AstraZeneca was one of the first vaccines that we had coming through, and we were all very excited to see the touchdown of the AstraZeneca in the airport, to only see that a few weeks later it was going to be sent back. And in a media briefing, AstraZeneca was changed to J&J. So for those of us who very interested in health policy and making sure that evidence is clear and transparent and that people can make the best decisions, it's incredibly difficult, and it's hard to trust preprints or press releases. So making informed decisions about policy and practice, I just want to speak a little bit about the principles. So evidence-based medicine has been around for quite a while now, and it talks about the conscientious, explicit, and judicious use of current best evidence in making healthcare decisions, integrating individual expertise and the best available research evidence. So conscientious being really thought through, explicit and transparent, and judicious, requiring judgment. So there are three parts here, is that the individuals with the expertise are the patient themselves and what they might want, the clinical expertise and the healthcare professional advising, and the best available research evidence. And in this way, an evidence-informed decision could be made in this shared decision-making process. And what kind of evidence should we be looking at? So this is a very reductive, simplistic way of looking at it. But in terms of working out what is effective and what is not, there are certain study designs that answer that question better. So randomized controlled trial where half the people get an intervention and the other half don't, that is really the only way you can tell if something is effective or not. And so randomized controlled trials would be the gold standard that we're looking for, particularly well-conducted, properly sized, so that they can answer the question. And a systematic review of randomized controlled trials would be the next level of information. And that's the systematic review is really the study unit that informs health policy globally. Other studies like cohorts, or what we've been seeing a lot with ivermectin, or case reports or individual reports, really, in the context of COVID, will have a very hard time showing that ivermectin works. So there are a lot of anecdotes of people saying, I'm using it, I haven't had any problems, and I haven't had this, or I've been giving it to my patients. And of course, if you don't have a control group, you can never really tell if that was, whether it worked or not. And that's particularly challenging in a condition like COVID-19, where we see, even in our country, that there's a 95% recovery rate. So 95% of people will recover anyway, or will, as it's a self-limiting condition. And so it's very hard to unpack what it means. The issue with all of these studies, particularly systematic reviews and randomized trials, which would be the best way to answer the question of does ivermectin work or not, is understanding what the quality of those studies are. So it doesn't matter if it's just a systematic review, you need to check critically, is it a good systematic review? Can we trust it? What is in it? And there's some very clear guidance on how we go about that. But that's not something that everyone does in their day-to-day work. So a lot of groups have been getting involved in trying to minimize the kind of the scourge of information, stop fake news, infodemic, and I really like Africa Check, which is a big group of journalists that do fact checking. And so there are different resources that you can go to check information. I wanted to give an example very briefly, watching the time, of chloroquine. So chloroquine, as Prof Moshabela said, so recently the review came out from the Cochrane Library, and we now know hydroxychloroquine does not reduce deaths from COVID, and it probably doesn't reduce the number of people needing ventilation. It caused more unwanted effects than the placebo, but luckily in the study so far didn't increase the number of serious adverse effects. But the bottom line is it should not be used to treat COVID. And given its lack of effect for treatment, the likelihood of any benefit for prevention is extremely low. But this is the chloroquine. Now, this is a very challengingly small type run, but the timeline of chloroquine, I think, is very telling as an example, because a year ago, or just over a year ago in March, we started, and this is where the timeline starts on this side, we started to see information about chloroquine coming through. So even before the 11th of March, and when WHO declared the pandemic, there was a pilot study of hydroxychloroquine with 30 people that said, we need a larger study. And not long after that, on the 13th of March, Mr. Regano and some colleagues released a non-peer-reviewed Google document, which has subsequently been removed. And then he also appeared on Fox News. And it just so happened that Elon Musk tweeted about the Google document, saying maybe this is something worth considering, chloroquine for C19. Now, Elon Musk has got a Twitter following of about almost the size of South Africa. I think it's around 47 million people follow Elon Musk. So the impact of this information and misinformation traveling around is tremendous. Not long after that, Trump comes out to say we're going to fast track approval of hydroxychloroquine and that this is a game changer. There's a French study that was published by Raoult with 42 people that's suggesting that there was viral clearance in 6 patients. So these are tiny studies that are coming out, but major pressure. And not long after that, I'm trying to see, but France actually authorizes hydroxychloroquine in severe COVID-19. Not much later, in the next month in April, the journal where the Dr. Raoult, who published the French study, they actually say that this study does not meet the society's expected standard, and they withdraw the paper. And then France withdraws authorization. So you can see this kind of story of early data, we're not sure one way or the other yet, people wanting to do the best that they can, misinformation coming out, not being properly interpreted. And so it rolls with hydroxychloroquine, including the FDA issuing emergency use and withdrawing it a few months later when the larger studies, Solidarity and Recovery Trial, come out and show that it's ineffective. So I'm just saying that this context of both information, hard to interpret, and regulatory responses happens generally, and I very much recommend this editorial. People have a chance to read about it. So ivermectin, I'm not going to describe much about it because I think Prof Naidoo has done a fantastic job. It is registered in many countries for human use for the parasitic indication, but it's not registered in South Africa for that, and it's not registered for COVID in South Africa. So there's been a lot of interest in ivermectin and people writing, trying to have this balanced view of, you know, does it work, doesn't it work? Let's wait for more data. And maybe to say, so we've seen, and I've just chosen one, but there are a number of systematic reviews that have come out. This wasn't a peer-reviewed one, and it's from a very much a colleague a respected colleague who's put out this information. But as I started to read it with my using kind of AmStar 2, which I've noted at the bottom, a way of appraising systematic reviews, some red flags started to come up. So there's and this is not only specific to this review, but a number of them, there's mixing of comparators. So it's not a fair comparison if you have ivermectin with hydroxychloroquine. We now know hydroxychloroquine doesn't work, and in fact may do some harm when combined with other meds. So mixing comparators, different doses, different populations, combining different study designs, very limited assessment of the risk of bias or appraisal of the quality of the studies that are included. So if you include a whole lot of very poorly reported studies, it's very hard to know whether you can trust the data. And then something that really stands out here, which is unusual, is that the author team are all authors, trial authors, and in kind of in systematic reviews, you generally try to keep an arm's length from the people who conduct the trials, because the trialists have they're invested one way or the other in the outcome of their trials and may not be seen as exactly free of conflicts of interests. So there are a number of issues here, and actually, but you know, Prof Hill does go on to say that there are many studies that they are not yet published or in peer review. They have lots of confounding issues. And he goes on that ivermectin should be validated in larger, appropriately controlled randomized trials. So even though his kind of bottom line is we don't know yet about ivermectin, a lot of people have taken some of the results and interpreted them in different ways. I think an interesting study that came out that maybe builds on the previous speaker's presentation is an analysis that some colleagues did at the Soweto Clinical Trial Center, where they found 5 different tablet formulations of ivermectin, none of them legal, and they found that 4 out of the 5 of them included other active medicines, so non-steroidal anti-inflammatories, analgesics, antihypertensives, antidepressants. So these illegal formulations that come in without any quality control about what's actually in them, when tested, the ones that people are using and paying a lot for may have other things that are, just contain other medicines that are not clearly reported or transparently reported, and that is majorly problematic. So just to add, the issue of meta-analyses, and so we've seen a lot from the different from Pierre Corey, from Tess Laurie, from Andrew Hill, and many others, is meta-analysis is a fine art. And there have been many examples of misleading meta-analysis if you're not careful in what you put together and how you interpret it. A very good example, I think, is magnesium sulfate, that for many, many years was thought to be a very good drug for people who come in with a suspected heart attack. And there were many early small trials that all showed very impressive benefit. until the large, adequately powered trial ISIS-4 that showed that there was actually no benefit in adding magnesium sulfate, and magnesium sulfate is not on the armamentarium of treating people with myocardial infarction or suspected heart attacks. So there have been examples of this where lots of small studies, because of just by the nature of having small studies, you don't always balance all the prognostic factors at baseline, and that causes a problem. Just checking, there we go. So systematic reviews must be scrutinized very carefully. So let's come to ivermectin. And just to mention the Department of Health rapid review. So this is the National Essential Medicine List Committee that as soon as when COVID started arising, by mid-March, they'd established a subcommittee to focus specifically on COVID reviews. And we've been able to use this rapid review methodology, drawing on what's already available out there in the literature. And if you want to see the reviews, you can go to the health.gov.za. The National Essential Medicine List Committee is a non-statutory advisory committee appointed by the Minister of Health, and they're responsible for the essential medicine list and standard treatment guidelines. And during COVID, we followed a very specific stepwise process to clarify exactly what is the question, find existing reviews, appraise their quality, check if they're credible, and then summarize them to inform a decision and a recommendation that then went on to the guidelines and the MAC looking at therapeutics. And they follow several principles, constantly trying to improve our methods and our process for transparency. Just to say, the decision is not based just on what works and what doesn't work. So it's not just efficacy and safety. So we look at a variety of things. So we look at the quality of the evidence, evidence of benefit and harms. We look at feasibility, values and preferences, acceptability and equity and human rights, and also at costs. So the group that looking at this, the NEMLC subcommittee group, have to think about a population perspective when making this decision. It's not about an individual patient decision. It's, can we roll this out? Is the evidence such that the benefits outweigh the harms and the costs are reasonable and it's feasible to do and doesn't increase inequity in order to make decisions? And that's the basis of their decision. So this is what they've put forward, and in a nutshell, it says there's currently insufficient evidence to recommend ivermectin for treatment of patients with COVID. Further evidence is anticipated. It was supposed to be due in January, but it's really not been flowing out. But when we look at the new studies coming out, there's nothing that would change the current recommendation that the NEMLC committee has put forward. So it's a group effort there. But because this was the 25th of January, I looked at the data yesterday, and I look on this website, COVID-NMA. This is a big global initiative doing living systematic reviews. A living systematic review is a review that is continually updated as the data comes in, incorporating relevant new evidence so that they can keep very much up to date. And this is one of the groups supporting the WHO SAGE group on the vaccine data. So just in a nutshell, the ivermectin trials of treatment for treating, what I have here is the author name, the setting, the kinds of patients, the study size, and then the risk of bias assessment. And you could imagine that green is a very good assessment, as in there's low risk of bias. The study is reported very clearly, and you can see what has happened there. When it is orange, there's some concern, and when it's red, it's high risk of bias. So this is the nature of the evidence that is informing the meta-analyses that are out there, and it needs to be managed quite carefully. And also to note, the studies are incredibly small. So in a nutshell, I'm just going to tell you about three main outcomes for ivermectin. Ivermectin treatment for clinical improvement. So this is either people leaving hospital or getting better within 28 days. And here we have in all the data in the meta-analysis, and I have the forest plot if anyone wants to see it later, of 167 out of 218 people had a clinical improvement, so 76% in the ivermectin group compared to 130 over 172 people who were in the study in the other arm at 75% in the standard care group. So what we can say is there's probably no difference in clinical improvement at day 28. And we use a specific grading of evidence I won't go into, but it's moderate certainty evidence, so that there's probably no difference. In terms of ivermectin treatment's effect on death, there were 9 deaths in the ivermectin group, 9 out of 617 deaths in the ivermectin group compared to 19 over 496 in the standard care group. Just note this, the numbers of events here, the number of deaths there. And the interpretation of this is we're still uncertain about the effects on cases of death. There's very low certainty evidence. The numbers are too few in this to be sure whether this was an ivermectin effect or due to random chance. And adverse effects, there was 212 in the one group with ivermectin compared to 199 over 396 in the standard care group. And we would say there's no difference in adverse effects between groups. So here, the numbers of adverse effects are high enough for us to really have a good sense of whether the data is mature enough and we can have high certainty about it. The numbers for clinical improvement are pretty high. The numbers of deaths, given that COVID is mostly self-limiting and 95% of people recover, you need big studies in order to really see an impact on death. And we have to work out what is the optimal information side, how many people should be in a trial to answer the question. So even in a systematic review, that the total number of patients included in the systematic review should not be less than the number of patients that need to be in a conventional study and the sample size that would be calculated for that study. I'll just touch on prevention. There are 2 trials of prevention. And there's only one that reports on COVID-19 cases that are PCR proven. And there were 100 people in each of the groups. So 100 people got ivermectin plus PPE, and the other group got PPE alone. It's not clear if there was blinding or anything else. But there were 2 cases of COVID-19 on PCR in the ivermectin group compared to 10 cases in the standard care group. Now, just looking at that, you can see the numbers are absolutely tiny in terms of our insights into whether this has any impact on COVID. And we would need a much larger study sample to answer this question. And it's not only the sample size, but also the risk of bias in the included study in ASSAf and how they report on this prevention component of their study. So there's very low certainty about whether ivermectin has any impact on prevention. So just for those that want to be a little bit more technical in terms of the clinical epi, so assessing certainty in results and whether we can really trust results is there is a known recognized danger of initial trials that have very impressive positive results. So early trials tend to have more impressive results. And the quote is, some early trials addressing a particular question will, particularly if small, substantially overestimate the treatment effect. And a systematic review of these trials will also generate a spuriously large effect estimate. And one of the issues is the confidence intervals that can be misleading because of what they call fragility in statistics. So there are reasons to doubt the size of the effect. First, it's if the effect size is much larger than we might expect on the basis of other COVID-19 prevention. So the other intervention for preventing COVID is vaccines. And you'll notice that those trials are of 10,000, 20,000 or 40,000 people. And what we have here for prevention in using ivermectin is 100 people in each group. So we're really at a stage where we don't have a lot of data. And concluding that there's a reduction of 80%, so from 2 cases in the one group and 10 in the other, an 80% relative difference on the basis of those 12 events doesn't really align with common sense. Intuitively, we have a sense of the fragility. And our intuitive skepticism is justified. If you move one of those events that could by chance have happened in the other group, the whole result loses its statistical significance. So let me just show that to you. This is a forest plot for those that are familiar, but it's just a graphical way of showing the results. And I mentioned ASSAf. There were 2 cases of COVID in 100 for the ivermectin group, 10 in 100 for the other group, which is an 80% relative reduction. If I move one of these events, just by chance it happened that it happened in the other group, because if you don't have a big enough sample size, there is an element of chance, and so let me just show you how that looks. If in Elgazar there were 3 events in that side and 9 on that, you already start to cross the null, this line of no effect over there. So that just indicates, and this speaks to the fragility of the confidence interval and the fragility of small studies trying to answer questions. We need more data. So health decisions on balance, we look at benefits, harms, costs, access and equity, feasibility to make decisions. And of course, with ivermectin, we're still trying to work out dose and duration, as Dr. Naidoo clearly spoke. So the take-home message is COVID-19 has resulted in a flood of information and misinformation, which is hard to navigate. Ivermectin evidence, the benefits do not outweigh the harms for a national program to be recommending this. We saw with treatment that there's really no difference in clinical improvements or side effects, and we can't see any mortality benefit. And prevention, it's just uncertain. So we all need to exercise this healthy skepticism when reading health information and check the evidence. Don't believe what I've said, check what I've said, and to make those informed decisions. And this is a great website, Informed Health Choices, that I recommend. So yeah, this is not just an infodemic. These are the info wars, and we all need to be better equipped to really appraise and understand the evidence that we face. So thanks everyone, and sorry if I've gone a bit over time. Back to you. Thanks.
Thank you, Dr. Kredo. Really appreciate that input. Yeah, I think that I feel like what you've done is shifted the discussion away from just looking at the science of it to actually say, how do you interpret the science when you're trying to make a policy decision? And I think that is really challenging, because what it does, what you've done here, for me at least for now, is you've actually made a good argument to say that, look, you can have early results that show benefit, and that's okay. And but some of those results could be by chance, but we wouldn't know until we have looked at larger studies. But now, if we have to, and so the people who are interested in those results, there's nothing wrong with it. But if we now have to make a policy decision, we now have to consider all these other factors that you stipulated. It really challenges, the way I've been actually thinking about it. You're right to say that a lot of us are thinking of it purely from an efficacy and safety point of view, and we just get stuck with dosage, with clinical benefit, 1 or 2 trials. But we are not necessarily saying, actually, how do you then move from there and the processes involved in getting to a policy decision? You've really challenged us there, and I think we've got some, a lot of thinking to do there. But thank you so much for that. I'm going to swiftly go to the last presentation and invite Professor Donrich Thaldar, who is at the University of KwaZulu-Natal. He's a professor of law and ethics. He is very active in terms of COVID-19 response, and including being part of a national evaluation of the COVID-19 response. And we're going to give him an opportunity to speak to us on this ivermectin issue from a legal point of view and an ethical point of view. Without a waste of time, Donrich, please take us through what you have to share for us. Thank you so much.
Thank you, Marcel. Thank you. And good morning, everyone. In today's talk, I will highlight the themes from the recent ivermectin legal saga that I think are of interest to a general non-legal audience. But first, let me provide a brief overview of the main events. Around December last year, the media started focusing on ivermectin as an alleged wonder cure for COVID-19. SAPRA responded with a press release, which we will look at momentarily. Essentially, SAPRA took a position against allowing ivermectin. By January, SAPRA was facing 2 separate lawsuits that called for ivermectin to be allowed in some form or another. By the end of January, SAPRA announced its so-called compassionate use program for ivermectin, which would allow healthcare practitioners to apply to SAPRA on a named patient basis for permission in terms of Section 21 of the Medicines Act to prescribe ivermectin for COVID-19. This announcement by SAPRA led to a temporary ceasefire in the legal proceedings, as the compassionate use program for ivermectin formed the basis for a consent order granted by the court on the 2nd of February. However, SAPRA's execution of the compassionate use program was so problematic that the litigation flared up again in February. In fact, the litigation multiplied. SAPRA was at that stage faced with 4 separate suits against them. Where are we currently? Well, I will discuss the current state of affairs at the end of my talk, but let me just make sure that my slides are properly shared. I just want to confirm, Mosa, everybody can see my slides?
Yes, we can see them. Thank you, Donrich. Go ahead.
Good. So this is my presentation outline. I will focus on these 3 themes. And as you see on the top right-hand corner of my slide, you will be able to track my progress through my slides. The meta theme of my talk is public trust. Public trust is essential for a government to successfully steer a country through a pandemic like COVID-19. And as I state here on this slide, public trust is built on clear and consistent messaging, respect for the rule of law, and transparency and accountability. During my talk, you can constantly ask yourself how the events that I describe reflect on these values. First, let us consider SAPRA's stance regarding ivermectin. We start in December 2020. In a press release, SAPRA made the following statements. First, ivermectin is not suitable for human use. However, any child with an iPad and access to Google could easily fact-check this statement and find out that it is, of course, false. SAPRA also stated that there is no evidence that ivermectin is effective and safe to treat COVID-19. The problem with this statement is that no evidence is absolute, which I suggest did not reflect the reality at the time. It would have been more accurate to acknowledge that there were observational reports, at least, that ivermectin may show promise. SAPRA appeared to simply ignore these observational reports. Was this good for building public trust? By the end of January 2021, SAPRA's position regarding ivermectin evolved. The chairperson of SAPRA's board stated that the evidence regarding ivermectin's efficacy to treat COVID-19 is in equipoise. Note that there is a big difference between saying that there is no evidence and saying that evidence is in equipoise. This also raises another issue. What is the appropriate action to take if evidence is in equipoise? I suggest the appropriate action would be to conduct proper clinical trials and for a regulator to insist on waiting for the results of these clinical trials. In March 2021, SAPRA still stated in its affidavits before the court that there is scientific uncertainty regarding ivermectin's efficacy to treat COVID-19. However, By this time, as you would have seen in the previous presenter's slide, a report has been published by Lopez Medina et al. On a double-blinded randomized controlled trial of 476 patients that demonstrated that ivermectin is in fact not effective for mild COVID-19. So should SAHPRA not have taken note of this recent report at that stage and have advised the court accordingly? Let's now focus on SAHPRA's position regarding the registration of ivermectin. From December 2020 through January and February of this year, SAHPRA's position was that ivermectin is not registered. Furthermore, in her affidavit dated 16 February 2021, SAHPRA's CEO stated under oath, I quote, "I must emphasize that, to date, there has been no application to SAHPRA for the registration of ivermectin." Beware the Ides of March. Around the middle of March, in the midst of 4 court applications against SAHPRA, there was a sudden change in SAHPRA's position. In her affidavit dated 14 March 2021, SAHPRA's CEO stated under oath, and I quote again, "I became aware of a medicine which is in the final stages of registration, in which the active component is ivermectin." She further states that this medicine, named Soolantra cream, will be approved within days. Quite a remarkable discovery. What would be the effect of SAHPRA's registration of a medicine of which the active component is ivermectin? No reason to guess. In her affidavit, SAHPRA's CEO makes it clear. I quote, "The effect of such a registration will result in compounded ivermectin being accessible to medical doctors without having to follow the program." In other words, off-label prescription of ivermectin for COVID-19 is now possible as long as you have access to a compounding pharmacist. If not, of course, you still need to follow the compassionate use program, or at least the medical practitioner needs to follow it, apply on a named patient basis to ask for SAHPRA's permission. The question, however, is where is the science in all of this? But keep this quote from SAHPRA's CEO fresh in your mind when you read the quote in the next slide. This is a press release at the end of March in which SAHPRA states, "The SABC placed an erroneous report that SAHPRA has agreed to allow the use of ivermectin for the treatment of COVID-19. This is grossly untrue, misleading to the public, and irresponsible, and could have dire consequences." My question is, who exactly is misleading the public here? I want to take a brief detour to point out something interesting. A few days before SAHPRA discovered Soolantra cream's application for registration, something happened in the litigation. The legal team of the applicant in the third suit against SAHPRA amended their notice of motion in what can only be described as a brilliant strategic litigation move. The amendment is about 2 pages long, but here is the core of this amendment. It reads, "Directing the first respondent, that is now SAHPRA, to formulate criteria to be used for evaluating applications in terms of the compassionate use program for ivermectin that are A, rationally connected to the aims of the program, and B, objectively measurable in the sense that evaluation of applications in terms of the program should not be based on or influenced by subjective beliefs of SAPRA or its employees, nor any other arbitrary consideration. The rest of the amendment deals with the publication of these criteria, etc. So if SAPRA were committed to transparency and accountability, they would have grabbed this opportunity to settle the case. Simply accept these amended terms and the case can be settled. However, SAPRA rejected these terms. If SAPRA were applying objective criteria rather than subjective arbitrary judgment when considering applications in terms of the compassionate use program, what is the harm in making these criteria public? In fact, transparency and accountability would require it. But if SAPRA were simply making subjective arbitrary judgments all along, it would be difficult for SAPRA to formulate and publish objectively measurable criteria. These are clearly very reasonable requests. The amendment, I mean, how does SAPRA convince the court not to make the amendment an order, especially in the light of the operational difficulties with the rollout of the program? Clearly, this amendment could assist in making the program work better. In my opinion, this amendment would have been very attractive to the court to make into an order. If SAPRA did not want to be forced by the court to function according to objective criteria, they had to think of a way out of this corner. So, just a few days later, SAPRA announced that they suddenly became aware of Sulantra Cream's application for registration. Was this discovery an escape mechanism? I refer to SAPRA's operational difficulties, and that's actually a euphemism, with the rollout of the program. Some of these difficulties moved into the realm of non-compliance with a previous order of court. This is a whole story in its own, but you can read more in my article on the topic. The link is there on the screen. So let's look at what happened in court just last week. Subsequent to SAPRA's registering of Sulantra Cream, it is for all practical purposes open season for ivermectin, with the only caveat that it must of course be prescribed and it must be compounded. Accordingly, all the applications, all 4 the applications against SAPRA settled on this basis of ivermectin being, or the possibility of prescribing ivermectin if in compounded form. But for reasons that should now be obvious to everyone listening to this talk, SAPRA would be liable for legal costs. As such, SAPRA settled to pay 1.8 million in contributions for the legal costs of the applicants against it. However, the High Court added its own terms to the settlement when the court made it an order of court. The court held that SAPRA must report back to the court and to the other parties every 3 months. After SAPRA's sudden changes in position and after its difficulties in complying with the previous court order, it is not difficult to understand why the court imposed this rather embarrassing requirement on our country's health products regulatory authority. SAPRA's response to the court order was to file further written heads of argument in which it argued that the court is not competent to give such an order. How does SAPRA's conduct align with respect for the rule of law? To conclude, let us read just one paragraph from the court order, which is based on the settlement between SAHPRA and the applicants. And this may come as a shock to some in the science community. It reads, SAHPRA is enabling the use of ivermectin for the purpose of treating or preventing COVID-19 at the discretion and responsibility of the prescribing clinician. However, one still finds this statement on SAHPRA's website. The heading is, SAHPRA has not authorized ivermectin for the treatment of COVID-19. Let's look at the previous slide again. It reads, SAHPRA is enabling the use of ivermectin for the purpose of treating or preventing COVID-19. So SAHPRA is enabling but not authorizing the use of ivermectin. Are you confused? To conclude, let's look again at these public policy axioms. Public trust is essential for a government to successfully steer a country through a pandemic. Public trust is built on clear and consistent messaging, respect for the rule of law, transparency, and accountability. I leave it to the audience to draw their own conclusions. Thank you, Mr. Chair.
Thank you, Donrich. I'll have to confess that I've had a few moments of laughter here and there with your sarcasm as you were presenting your talk. Okay, so we don't have a lot of time, but I think I just want to touch on some critical questions that have been raised for the two of you. And it's really unfortunate that Professor Vinny Naidoo is not here with us today, but I was looking in the audience, we had some veterinarians. I know that Dr. Marianne Lomberg is in the audience as well and was willing to take some questions, but perhaps let's not dwell on the more technical questions. Let's dwell on the substantive issues that I think would help us in terms of reaching conclusions for today. I want to start off by saying that, in the comments, I've also noted that, people have challenges with a lot of, groups that are pushing for ivermectin. Our duty today is not to try and discredit anyone. We're not trying to, prevent anyone from voicing concerns. Yes, there are issues there about whether people should be held accountable for what others might consider misinformation and disinformation. Yes, but that's not really the focus of our discussion today. Today, I think that what we are just wanting to look at is to say that from the ASSAf perspective, what is it that we see as the evidence? What are the issues that we are having to grapple with here? And what is the responsible thing to do in terms of what is best for society? Now, that is not to say that, we really, we know that it is an emotive issue. It is a divisive issue, this matter of ivermectin. And I just want us to focus on what has been presented and not really attack each other. I would really appreciate that. So let me start with you, Professor Thaldar, in terms of the predominant question here, following these decisions by the court and the communication from SAHPRA, is that we are being given an impression that ivermectin is being allowed to be used. It will be prescribed by the doctor. It will be compounded and dispensed by a pharmacist at specific pharmacies that can do that. But now, who takes liability? Because one of the concerns we've raised here is issues of potential toxicity. And we know that doctors are not trained to evaluate the evidence the way that Dr. Kredo can evaluate evidence. But at the same time, we are going to find a situation where they will prescribe, and whether based on knowing or not knowing, they may end up prescribing something that can be problematic for a patient. I would like to know from you, under the circumstances, who is going to take responsibility? You have said it yourself that it does look like SAHPRA is not really wanting to shoulder the responsibility for ivermectin in as much as they are enabling its use. They have not authorized, but they're enabling. So can you comment briefly on that? And here I'm interested in what is ethically in the benefit of society.
Thank you for the question, and I definitely share your concern. So we all know what the current position is. It can be prescribed to be compounded. You ask about liability, but that's a very difficult question to answer based on the current evidence. I think I can only recommend that if there's a physician, if there's a medical doctor who wishes to prescribe ivermectin, we've seen the evidence. I seriously doubt whether it's a good idea. Well, there's clearly not sufficient evidence to use ivermectin, but if an individual medical practitioner wishes to prescribe ivermectin, he or she can legally do so. As with any other medicine, it's an off-label prescription. So it's like prescribing any other medicine off-label. Such a practitioner should then make sure that there is proper informed consent. Share with your patient exactly what is known currently. What are the potential risks? What are the potential benefits? And clearly the evidence is that initial cases show that there's promise, but clinical trials, large-scale, well-powered clinical trials are still underway. So we don't have finality. That one study that at least has 476 participants, the one by Lopez Medina, that one shows that there's no benefit amongst patients with mild COVID-19. So these are the facts that should be communicated by the medical practitioners to a patient before prescribing it. In other words, there should be proper informed consent. Regarding your question regarding liability, that's a very loaded question, and I would rather not venture opinions regarding that at this stage.
But would you agree, Donrich, that it is something that society needs to be aware? The doctors that are going to prescribe and the patients who may want to use ivermectin and may request it from their physicians, they Absolutely. Need to be aware of this, right?
Absolutely, and you know, SAHPRA has a statutory duty to control medicines, and it would have been great if SAHPRA were just consistent with their messaging and transparent with their criteria all along. That would have assisted, that would have built public trust, both among medical practitioners and among the public generally. And if there were press releases that were actually believable and factually correct, that could have assisted massively. So I think you will share my concern with the current situation, because where does the public and medical practitioners get good, factually correct, accurate information from in South Africa?
So the last thing that I just want to ask, or maybe the second thing that I want to ask you, and maybe this is for you to really consider and think about and advise us on, is the fact that my impression or my understanding is that SAHPRA was not keen on approving even compassionate use of ivermectin. It was only after there were reported cases of toxicity and somewhere in KwaZulu-Natal and a couple of others, as well as increased number of cases of smuggling of ivermectin, that we saw a change. And I am not necessarily connecting these two things, but just listening to the head of SAHPRA speaking, the impression I got, and the chair of the board, the impression I got was that in a way they were trying to as you say, enable the use of ivermectin, but in a safe manner that can be controlled under compassionate use to minimize a situation where people are using illegal formulations and smuggling and so forth. Now, can you comment on that and let us know whether in your analysis this could be the case, and if it is, did SAHPRA get itself in trouble given the fact that they now had to follow through, and the decisions we're seeing in the courts are subsequent to the allowance of compassionate use?
Look, I'm not involved in SAHPRA, so I can't speak for them, and I can't speak to their motivations. I can only speak to what I read in their press releases, which sometimes I wonder who's writing those press releases, and I can speak to what I read in the voluminous affidavits filed by SAHPRA. So one would assume that if SAHPRA officials like their CEO make statements in the affidavits under oath, that those statements would be accurate and truthful. So that is what I rely on in my assessment. But what the motivations were, political motivations or anything else, I can't comment on that. I can only say that SAHPRA has a very clear statutory mandate. They must ensure that if medicines are available in this country, those medicines must be safe, of quality, and efficacious. And it's as simple as that. That's the mandate. So if people are smuggling it, doing this or that, those issues should not influence you. You have a very clear mandate, and you must comply with your mandate. That, in my view, should be the answer.
Yeah. No, thank you. And I think the other comment that was made by one of the attendees is that compassionate use would have been adequate if the monitoring and their processes were actually efficient. If they were responding and they were, or if it was working, the impression that colleagues have is that that could have been sufficient. But let's move.
If I can quickly respond to that.
Sure.
The problem, of course, with the compassionate use program, well, firstly, I think the operational problems were just of such a magnitude that that the whole program stumbled.
Right.
But apart from the operational issues, the problem is with the signaling. What is the signal that you send to the public when you start with the compassionate use program? Because what you say is, oh wait, it's not registered because nobody has applied for it to be registered. In other words, for that technical reason, it's not registered. So now you provide a program for its use. So in principle, you acknowledge that this at least has the potential to be used as a cure or whatever the case may be for COVID-19. That is the messaging that you're sending to the public. You don't want to allow it because for a technical reason, no formal application for registration, but we'll follow another route. I think the messaging really needs to be very clear and consistent. And I'm afraid that by starting with a so-called compassionate use program, the messaging was just completely off target, in my view.
Yeah, thank you for that. So, Dr. Kredo, you made a very interesting case when you moved one event from a group into another group. It was Donrich spoke about a brilliant litigation move. That was a brilliant scientific move to make your case here. Now, here's a tension. One of our attendees is asking a question that I would like to direct to you about. The impression you're giving us is that when the body of evidence needs to be compelling for us to make a confident policy decision. But now we have a situation where the body of evidence is not compelling, per se. And I know that some people might disagree, but let's accept, based on the analysis you've done, that it is not compelling. What does it mean in terms of research studies that look at safety and efficacy. A lot of these trials, they look at safety and efficacy, but they don't look at the other dimensions that you have raised that need to be considered for policy. So what does it mean? Because we are under the impression that the moment a study has been done and it's shown to have safety and it's shown to be efficacious, that's enough for it to go into policy. Can you help understand that? And in this, you know, we also have a situation where the safety profile has not been established. So we cannot really compellingly say that it is safe and efficacious given the issues that we've discussed, that were discussed by Professor Vinny Naidoo around the pharmacokinetics. So can you help us how to think about that? And I'm speaking from a perspective of science, right? And people who do science, who do research, who evaluate research. How should we be thinking about the evidence, since it's not enough just to have safety and efficacy in order to do policy?
Thank you. I think that's a great question. And it comes back to the issue of the perspective that we take when you make a health policy decision, which is that public health programmatic perspective, which is quite different from when I'm sitting opposite a patient and making an individual clinical decision around that person and their needs and what they're happy, you know, what they're comfortable with. So we take that out of the equation. At a health policy level, all of those factors come into play, and that is the standard approach for guideline development globally, particularly with WHO, and we are incorporating that, and that is happening in South Africa with the EML. But an example would be the trials will still focus on efficacy and safety. That's what their job is. They tell us about causality, and we need good quality trials. And I have only given a snapshot of the studies that looked at ivermectin versus standard of care placebo. There are loads of other studies, ivermectin versus doxy, doxy plus ivermectin versus ASSAf. There are endless other ones, but you know, I already went over, and I apologize for that.
No, it's fine.
So just to say, I didn't present every single study today. I focused on a subgroup that makes the most sense, which is ivermectin versus placebo or standard of care. The other factors are critically important, and there's a growing science of how we fill those gaps in knowledge. So, for example, costs, you know, when do we need a full economic analysis? When are we just doing a back of the envelope assessment of affordability? So sometimes we're simply looking at, can we afford it? How much does it cost? How resource intensive is it? Sometimes you need a full cost effectiveness if you have effectiveness data, which we don't yet. For the other issues, acceptability. So increasingly we're using qualitative evidence or doing surveys or speaking to the practitioners or patient groups to find out, is this acceptable? Would you be okay with this medicine compared to this, or a change from an IV to a subcutaneous, whatever the case may be. Feasibility, can we access it? Is it registered? So the essential medicine list guidelines generally don't recommend medicines that are unregistered. So that's one of the factors that they look at. How accessible is this medicine? Is it feasible to roll it out? And then finally, and importantly, is equity. If we recommend this, is it only going to be the Western Cape and Gauteng in the big hospitals you can get it, or can you get it in every clinic throughout the country? So equity and access becomes part of it. So there's different kinds of evidence. There's trial evidence, and then there's the rest. All important.
Okay, so basically what you are saying is that we need to also foreground other studies that help us think about how to operationalize the evidence we get from trials. I don't think we talk about that enough, actually.
Yeah, it's very well put. It is about what are the implementation barriers we might run into. It's all very well to say, this looks great, let's use it, but what are the other factors that you start building in? And as you think through your policy decision, you start thinking about the implementation considerations, subgroups to consider, M&E, you know, that all comes into the process of the health policy decision. You spot on.
Yeah, so let me ask you the next question. I'm gonna play a bit of what they call devil's advocate. I don't like that word, but let me just use it to say that as a scientist who has put forward the evidence that we should not necessarily support use of, and as a group, not you personally, but as a group, the evidence not to adopt use of ivermectin, given the, as you say, the nature of the evidence we have currently. How do you make peace with that, knowing that there is so much public pressure and political pressure to actually accept and use ivermectin? How do you deal with that? Because this is part of the tension, right? This is where I often say that, look, there is a policy debate or a political debate, but there's also a science debate. So you might be engaging in the science debate, but if you've blocked everything else, then it becomes difficult to take into account the other views. Now, I'm just wondering, how do you do that? And it was the same with hydroxy. There was international pressure, but maybe far more so with ivermectin, including even the court cases. Yeah.
Yeah, I think there's a lot we don't know about why it's so popular in certain countries and others. But to be honest, Prof, it hasn't been easy. I have looked at this data from every different angle because I'm thinking, how can so many people be so convinced about it? What am I missing? And I have, as you say, it's a group effort, it's a committee decision, and the evidence is reviewed. I've reached out to my colleagues at WHO to say, why aren't they proceeding with the ivermectin therapeutic guidelines? They say they're not enough, the studies aren't big enough yet. And reaching out globally to colleagues that work in the evidence space to say, what am I missing? And so I have looked at it from every angle, and there's a lot more in the clinical epi and understanding the meta-analysis and why things are kind of misleading. And I gave the example of the magnesium sulfate, where a lot of people believed in it until we had a big enough study, because early studies and particularly positive reporting and not all of the negative studies being reported, so some publication bias is potentially driving some of this misinformation. So can I say, I think one of what's come to light for me are two major gaps that I think ivermectin has shown. One is the gap in kind of all of our ability to kind of appraise and have that healthy skepticism, and we really need to work within our health professional undergraduate programs to help people to become more health evidence informed, to be able to unpack that kind of information, which is very challenging. And the other gap is that I think managing in the COVID, and particularly in the waves, managing COVID was under huge pressure, and there hasn't been very clear information on primary care management for COVID. So in a way, there's been a gap in information, which is being filled by people who are needing to make these critical decisions. And I think there's more that we can do in terms of providing very clear guidance for practitioners on what they should and shouldn't be doing. And for example, the use of multivites and everything that goes with ivermectin. We need clear guidance for everyone. And I think that might help address a gap.
Okay, so thank you for that. And I appreciate your honesty in saying that it's difficult, and I can imagine that it is. But I would like to wrap up. In wrapping up though, I would like you to speak, Donrich made the point that if you are a regulator in South Africa and you are saying there's not enough evidence, as your conclusions have reached, then the recommendations becomes that we do these studies. We do these studies. Where are we in doing these studies? And we have seen the power of doing studies, especially even doing studies locally in South Africa when it came to COVID-19. But where are we with the clinical trials for ivermectin? When do we expect an answer? You said that we don't expect an answer soon, but can we get some sort of direction in terms of where we are at and where we're headed?
So when we did our rapid review for the NEMLC committee, when they looked at that evidence, we understood that the evidence was imminent, actually coming soon, but we've only seen a couple of trials coming out, the Lopez Medina, the one. So I'm wondering, where are those studies? There are 91 studies registered globally of ivermectin trials. Why aren't we seeing the data? It's now April. So I have that question too. When I went to look at the clinical trial registries, I see a lot of them said they completed recruitment last year. So in effect, they should be finished. We should be seeing the data. And that's one of my concerns about why are these other studies not coming into preprint or publications. So I hope that data comes out. I think it will fill in a lot of gaps and it will be helpful. We want to know one way or the other whether we should use ivermectin. The trials in the country, you see, if you have 91 studies already registered, isn't it duplication to do more studies? But as I understand it, there were two groups interested in this, one in the Free State and one at Stellenbosch University, and I don't know more than that, but hopefully they can be gathering information relevant for our context.
Thank you so much. Colleagues, we are 5 minutes over time. I would like us to wrap up, and for me to really take this opportunity to thank our presenters, and I would have really liked for Professor Naidoo to also be here so that we can discuss some of these issues. But as you can see, this issue is so complex and there are so many facets to it. But I hope that we have dealt with some of the core issues. As far as I'm concerned, I'm feeling a little bit better with what we have had today. And I do recognize that this is a debate that is going to continue. I do, though, want to ask that let's make sure that we don't conflate the different conversations. When we are having a scientific conversation, let's have a science conversation, and let's have it with level-headedness, just so that we can be fair. And when we now bring in other dimensions, because there's so many other dimensions now involved, then they kind of really cloud things. But not that they're not important, but as Dr. Kredo has mentioned, we need to be thinking of other studies like discrete choice experiments and so forth to try and understand some of these things that will help policy decision-making, the blind spots that we have. So I would like to conclude with those words and really again thank our panel. And but before I close, I have to let Himla say the final word. But Donrich, thank you so much for today, and Tamara, thank you so much. Really appreciate it. And to Vinny also in absentia, he did an amazing presentation. And to Kuto and the team at ASSAf, thank you. Thank you, Himla.
Thanks, Musa and colleagues. This has really been a riveting engagement among the panelists and as well as our audience who have been using the chat and the Q&A quite effectively. It is unfortunate that we couldn't go through some of the questions that have been posed in that chat, but we are taking note of them. And I will try to get a response to some of those questions. And when we put out the link, hopefully we would have had an opportunity to address those, because I think some of the comments and questions raised are particularly valuable in the context of the conversations we've had. I must echo Musa's comments about how nicely the three presentations kind of interwove one into the other and giving, the kind of medical insights. The meta-analysis, Tamara, was really, really good. And I like the way in which you actually brought into question the use of such information in policy briefs and in advising governments in decision-making processes. And of course, Donrich, with his very strong and eloquent way of taking issues in a very objective way, asking the questions, providing the information, and challenging us to think about what is it that we want in the messaging that comes through from the authorities that we as mere citizens give the power to act on our behalf. So it was very nice to see him challenge the whole process by SAPRA. And we did try to get SAPRA representatives to be part and parcel of this conversation. And unfortunately, no one was available to be online today. So we did try to get a balanced perspective on the issue. Colleagues, thank you for all of those of you who have stayed on. It's really, really great that you could share this time with us. And ASSAf does regularly bring topical issues to this discussion portal. So we encourage you to look on our website and pass the word around to your friends if you see a notice of what is going on. So thank you all. Have a good day going forward. And we may come back to some of you for some comments to the questions. I have tried to save them, and so has my colleague Ian. So we will put together a good list of questions and comments separately so that you get a holistic report at the end of it. Thank you all. And once again, Musa, thank you so much for sharing. And remember, you owe something. I'm waiting for it.
Yeah, it's on its way.
Cheers all. Take care.
Thank
Bye-bye.
you, everyone. Bye.
Bye-bye. Bye-bye.
Bye, everyone. Thank you.